thank you, everybody, for giving me the great honor of being your keynote speaker today. This is a lecture that I'm particularly proud of, and one that I think points out to the world, if you will, that we do have a major problem. And that major problem is understanding diseases as they move through the bloodstream, and even opening our mind to saying we have a problem. And I'm going to show you some thoughts and data on this about how this has been rejected as a problem. I think it's a problem. I think it's an underrepresented and underappreciated problem, and it may be actually a vector for transmitting the virus. But of course, we don't know that because people, at least in this country, the United States, are unwilling to investigate it, and we've seen that in the past. In the past, people have been unwilling to investigate things like West Nile virus. Indeed, at one time, they were unwilling to investigate AIDS and blood transfusion. So history repeats itself, unfortunately. To be talking to Africa about an elephant in the room, well, we won't even try to make any funny jokes about that. But really, this is an elephant in the room, and a big one. So I'm going to outline some of my thoughts on pandemics. We're going to talk a little bit about the underlying science of COVID-19. COVID-19 is we are rapidly gaining more and more information on it. I participate once or twice a week with 250 of the world's best scientists on COVID-19. And what I think either the lay public or the average physician knows about it is a far minuscule amount of information compared to what's been investigated and found out. And in one way, medicine is lurching way ahead because of it. I'm going to ask the question, is it actually hematogenously spread? Can it be spread through the bloodstream? And my answer to that, as you'll guess from this, is yes, it actually can. And then we're going to take a look at some pandemic models of the blood supply. Whether we show that the virus is actually in the blood supply or not, it is affecting blood supplies throughout the world. And that has actually been modeled. It's been modeled by a number of people, at least in the United States. And then there's a whole lot of other things that have to do with blood and such. I may not get to the last one there, this treatment, because I may actually, frankly, run out of time. There's just so much information there for us to go through. I'll give you a couple of cases. First off, just to bring up the frame the background, and this is one case that we had, which was a 63-year-old with chronic AFib on warfarin presented to the ER with shortness of breath, unstable AFib, rapid ventricular rate, and you can see some of his lab work up in there. And he was, we were called to help with him in the emergency room or in interventional radiology. His COVID test returned positive, and he remained in the ICU in cardiogenic shock for hours after he underwent a thrombectomy. Now, one of the things I'm going to tell you about is, and I think everybody knows this, is that COVID patients become very hypercoagulable. So how do we deal with that in medicine, and how do we deal with the hypercoagulability? And I think I will also make the point eventually to you that everybody, if they have COVID long enough and they are hospitalized with it, will not only get heparin, which of course brings up the whole heparin-induced thrombocytopenia side effects, but they will become super hyper thrombotic. And that alone causes problems for us, not only in our decision-making about coagulation and how to treat it, but also in terms of how to use certain blood products and stuff. And here's another one, chronic secondary effects of ARDS going quite wrong. A 52-year-old male, past medical history of diabetes, hypertension, obesity, sleep apnea, very, very ill. He's COVID positive by PCR. Over 3 weeks at an outside hospital, progressed to ARDS. He was intubated, sent long distance here. We here at University of Florida have the highest number of ECMO patients from COVID that I know of in the country, and we have the largest series of patients who have undergone lung transplantation secondary to their COVID. I can tell you that I've done I've done 9 of them myself, COVID transplant patients, and I've never seen anything like it when we open the chest and we actually look at the lung. As we remove the lungs for the transplantation, their lungs are the stiffest, most leathery things I've ever seen. And a couple of them, you can't even stick a 15 blade scalpel into it, bounces off. That's how tough they are. So at any rate, these are problems that occur to us, and they may not be strictly blood problems, but they have connections with that. Patients who are on ECMO for long term, who have who are undergoing ECMO for 40, 50, 60, 70 days. We actually, I'm working with Florian Falter and a group at Papworth in Cambridge, and we're looking at blood utilization. And actually, the blood utilization is less in the COVID patients because they're prothrombotic. They don't bleed, but they do far, far worse. So everybody knows that COVID, and these are perhaps old data, December 2020, now March 2021, the data keep going up and up and up. And I think now the death rate around the world is over 5 million. Death rate in the United States is over 700,000 and rising every day. So it's absolutely scary stuff. But here's the other thing. This is more than just a blood issue. Yeah, the blood issues have effects worldwide, but they have political issues, and the political issues. One could go into a political science lecture of just what are the political issues as these pandemics rise and fall. Governments, frankly, will rise and fall based upon these pandemics and how we respond to them, and the human response to them is dramatic. And one of the human responses might be, acceptance of blood transfusion, or the willingness to investigate whether indeed it is present, or whether the willingness to investigate is blinded by people willing to put their blinders on to say, we won't look at this because it's just not politically or socially acceptable for us to ask the deep scientific question, which is, does the virus transmit by blood transfusions? So here's a fascinating thing, that viruses are, it's very easy for all of us to consider that viruses are somewhere on the evolutionary scale, that they must be sort of prodromal or pre-biologic or pre-bacterial entities. But indeed, we think that they're actually a throwback, that if you think about it, a virus cannot exist without having a working functional cell. A virus cannot replicate itself without having a host. As a pathogen, it must have a host to go into, to infect, to force that host to make replicas of it, proteins, lipids, and reassemble itself. So a virus cannot exist on Earth without already some other host life form for it to be able to infect. So we think actually viruses may have arisen from other genetic elements that gained the ability to move between cells, and then therefore they came somewhat after the actual evolution of life on Earth. And this artist concept is kind of beautiful in its own ugliness. And although it seems so simple, it's such a complex little beast. Maybe beast is the wrong word for it, but it is really complex. So when the COVID-19 infects any given cell, and it infects cells throughout the entire body, when it infects, it can replicate 100,000 to 1 million viruses per cell within about 2 to 3 hours of the time it goes in and replicates. But let's look at a few factoids about infectious diseases in mankind. And lo and behold, the first infectious disease or pandemics that we know about were in early China, 5000 BC, where we can now find mass burials. And it may be that in Athens in 430 BC, there was actually an Ebola epidemic that appeared to be, from actual written records from that far back, there appears to be a hemorrhagic fever that was bleeding in the mouth and the lungs. It sounded a lot like Ebola, but it was some Ebola-like thing. Here's one that I didn't realize, that in 15 years, they said in Rome, but it must be the entire Roman Empire, that a plague from bubonic plague killed 5 million people. So we shouldn't forget, really, that the largest die-offs of mankind have not been wars. They've been plagues. They've been infectious disease disasters. And how we behave to them in terms of medicine does affect how those plagues are either wiped out, they run their course, or potentially we serve as vectors to make them worse. These are ones through more modern times. And of course, in West Africa, you guys are particularly, unfortunately, familiar with the Ebola disasters. So let's look at a little bit of underlying science. I know it's complex, but this is something about how the virus works. We all know now that it seems to gain its entry into the body through the respiratory tract, largely from inhalant of respiratory droplets or dried respiratory particles that are carried. The particles that seem to get in are about 1 micron in size. The virus itself is, tens of thousands of times smaller than the 1 micron in size, but it appears that the 1 micron size is what's really important. So all this anxiety about, super small N95 masks and stuff is another whole discussion one could have. But the virus attaches to cell surfaces through these glycoprotein binding sites, what's been called the ACE, the ACE protein, of which the protein on the surface of the spike protein on the surface of the virus that actually recognizes angiotensin converting enzyme. But that's not how it gets into the cell. The way it gets into the cell appears that it actually goes in through an adenosine nucleotide pore, where adenosine deaminase, which is the enzyme that binds adenosine on the surface of cells, and we all know that adenosine is a profound intracellular messenger, that when that that binding site for adenosine deaminase is underpopulated, the virus sneaks in through that pore. And once inside, it rapidly replicates and it does its damage and, of course, kills the cell. It takes over the cell that it's in. It consumes massive amounts of energy within the cell. And what's the energy? ATP, adenosine triphosphate, adenosine diphosphate, and about 1/3 to a quarter to a third of the actual messenger RNA of the virus is adenosine. So it eats the ATP from inside out. It consumes it not only to force the cell to make proteins, but it consumes the adenosine to replicate itself. And then it goes out. And where does it go? Well, it goes throughout the body. And this is where the blinders come on, I think, for many of us in medicine, is the lung a little vascular? Yeah, you bet. The lung is super, super vascular. So once the lung infection has occurred, then the virus has the portal to enter the body and hematogenously spread throughout the body. And if it stays isolated just in the lung, maybe we don't have so many of the horrible side effects that we know of, like the neurologic side effects. The virus has been found in almost every tissue throughout the body. As again, I said, the inflammation is complex. If you inflame the lung, you're going to turn on all kinds of upregulations of white cells and such. And this is something I study quite a bit. the invasion of killer T cells into the lungs. We'll talk about that at the very end. But the immune system carried by the bloodstream has a huge impact on this. And it's not the overwhelming viremia that kills our patients. It's the overwhelming response to inflammation, of which our bodies have an explosive out of normal event that eventually kills patients. And I think the more we understand about what individual patients have as a predetermining series of factors that make their inflammation go wild versus them being able to contain the virus and survive will make a difference for a lot of our understanding. So about 1 in 6 will have complications that are life-threatening. And that's about what we see in our hospital. About 8% of our patients, about 8 to 9% of our patients that appear in the emergency room eventually die of COVID. Once you're in our ICU, 45% of them die of COVID. And that really hasn't changed a whole lot. So, and they die of a cytokine storm, or they die of end-stage organ failure secondary to runaway inflammation. And here are the complications. We don't need to go through them all. So does COVID spread through the bloodstream? Interestingly, when I posed this to some blood bankers in just about a year ago, maybe a little bit before a year ago, I was told that can't happen. This is a respiratory virus. And these were people at the very, very high end of American Association of Blood Bankers. They said, this is a respiratory virus. It can't spread through the bloodstream. This is not like AIDS or hepatitis or West Nile virus. This is not a hematogenously spread virus. And I said, well, wait a minute. It has been found in the heart. How do you get from the lungs to the heart? Does it just walk on over? No, it has to go through the bloodstream. It's been found in breast milk. How does it get from okay, those are both close to the chest, but we can be a little bit more medical. Yeah, there's only one way it can get there. It's been found in the fetus from children are born with COVID inside of them with the mother if she's got COVID. So it doesn't always happen, and of course there's been widespread neurologic dysfunction, and active COVID virus has been found in the brain. So how does it get there? It has to get there by the blood. And as I said, when you've got 100,000 to 1 million virus particles coming out of each dead cell in the lung, some of that has to go into the bloodstream. And here's cases in myocardial tissue with active COVID virus stained for, found in patients with myocarditis after having lung COVID. So, of course, the only way we find this out is at autopsy. And the only way we find this out at autopsy is somebody's got to suspect it. And somebody's got to be willing to go and investigate it. But it's there if you want to look for it. And so in the end, COVID is an endothelial disease. And in the end, COVID attacks all these various different organs. And guess what? In the end, there are ACE receptors on most endothelial cells. There are angiotensin converting enzyme receptors on most of those. Yeah, the lung has the highest concentration in the body because that's where we tend to convert angiotensin 1 to angiotensin 2. But it's present throughout the rest of the body. And guess what? There are ACE protein receptors on the surface of every myocardial cell. So we are susceptible to it all throughout. So obviously, once it goes throughout, it creates this cytokine storm. But it can create the cytokine storm just within the lungs. But it can also create those cytokine storms once it gets to various different parts of the body. Of interesting and something that may be important to some of the people in Africa is that acute tuberculosis causes the same cytokine storm. Yeah, you can have chronic tuberculosis and horrible bad outcomes from that, But if you're going to die from acute tuberculosis, it's the exact same mechanism. It's a pulmonary acute cytokine storm. And some of the work we're doing right now with efforts with adenosine, inhaled adenosine, we think may be useful in Africa for treating patients with acute tuberculosis and trying to reduce that cytokine storm. And I mean, there's lots of this kinds of data that's out there about which cytokine peaks first, second, third. I'm not going to go into it, but the cytokines, the TNF alpha is explosive. And TNF alpha, of course, triggers complement. That triggers all kinds of agglutinations and other things that go on with red cells breakdowns, and it gets more and more and more complex. And so here's where I'm trying to get at with the blood issues. So back when things originally happened in Wuhan, China, and the disease was rampant in Wuhan, China, the Chinese blood bankers actually had the foresight to test some of the blood they had, and they tested blood from patients who were actively infected with COVID, who had acute respiratory, so ARDS, and they found in 4 of those patients that they could actually recover virus from inside the blood of the patients they were testing. Now, they didn't test anybody who was asymptomatic as a carrier. These were patients who were actively diseased. But so we don't know if you are a carrier, or you have just mild COVID, or you have early COVID, or you've just reported to the emergency department with cough and sputum production and mild fever. What percentage of patients can be found to have active virus present in their bloodstream? We don't know that. But in Korea, they actually started testing the blood. They started testing the blood in their blood banks, and this is a single case report that's out there, that they tested the bloods in the blood banks, and not only did they find COVID, but they found a patient who got active COVID disease from a blood transfusion. So when I brought this to our blood bankers in the United States, they said that can't happen. I said, well, here it is. It's reported in the literature. Well, it's a lung disease problem. It's not. Why would we test? We'd have to test every unit of blood in the United States. Have you ever heard this before? Have we ever heard that we shouldn't test because this just can't happen? And I'll put it to you this way, that if one were to get COVID from a blood transfusion in a hospital, how would you know it came from a blood transfusion? It would be blamed upon the patient came into the hospital, was somewhere exposed within the hospital to COVID, and that's how they got COVID. Nobody would ever investigate. Nobody would ever put 2 and 2 together to say, hey, we need to investigate that. So that's the state of the art right now, which is that there are these reports out there, but they're being ignored. And they're being ignored probably because it is a huge Herculean task and huge amounts of money to go back and test it. Not to mention which, what's the political fallout worldwide? And what's the catastrophe that happens to the blood industry worldwide if we now publicize that, hey, COVID's in the blood supply? So at any rate, what are the preventions? No person having COVID should donate blood for a minimum of 21 days after infection. Is that enough? And there are no US recommendations that I'm aware of that absolutely forbid it, although they say to me, well, we screen people for fever, and if you've been exposed to COVID, you just shouldn't donate blood, but that's not actually discussed. And when COVID came up in the United States, when it was rampant in the United States, the number one thing we did at that time, because blood was so scarce, was that we got all of our blood supply from hospital workers, and who were at that time most likely to be exposed And who were most likely to be asymptomatic carriers were the hospital workers, the nurses, the doctors, the people that worked where COVID was all going. And so when we had a first crisis, we went immediately to those people. And when I talked to blood bankers, they said, it can't happen because we never had any, when SARS epidemic came around, we never had any SARS found in the blood supply. So COVID's just like SARS, it can't happen. I said, well, wait a minute. As I remember when you got SARS, it was fast, it was disastrous, and it was nearly universally fatal. And there was no asymptomatic prodrome of people that might have the virus. And so I get it that you wouldn't look for that. And so, as I said, in March to June, 20,000 blood donations, at least in the United States, came from people. And so we have really no idea, but we may have made a mistake by saying, well, we'll just go to the people who are most likely to get the disease because they're the ones who will roll up their sleeves and give the blood. So let's learn from history and the viruses. And if you look at the history of blood banking, it's not so good about AIDS and hepatitis. It's certainly not so good about hepatitis. It wasn't so good about AIDS until 20 blood bankers in France were jailed. And it hasn't been so good about it hasn't been so good about West Nile virus either. And we can talk about that maybe a little bit later. But through January to June of 2020, the blood supply, at least in the United States, dropped by 85% in blood donations. And still in the United States today, we are having regional blood shortages routinely. It in some places is worse than others. So I wrote an editorial for the journal Transfusion, and it was rejected, out of hand, rejected. I said, when blood is not an option, medicine on the brink, we cannot take the risks. And I was focused on the need at that time for a blood substitute or an oxygen therapeutic. And my point was not to just focus on my world, but my point was we have a pandemic and we don't know whether the blood supply right now is safe or not. Perhaps we ought to figure out a regulatory way of getting an option. And it was refused that my editorial was too strong and we couldn't publish that. It was just too strong. So I'm glad to share it with people if you want to see it. But lo and behold, in writing that, I discovered something that 2 years prior to the pandemic, 4 years prior to the pandemic, the United States government sponsored a computerized study of what would happen to be ready for disaster preparedness. And so this is an article that was in Disaster Public Health Preparedness, not a journal I read all the time, okay, but a fascinating one. And what they looked at was, what's the U.S. blood supply like? How does it work? What are the interactions to have what's called a just-in-time supply or a stock and flow system? And lo and behold, they created computer models. And this is the stock and flow system in the United States that, it's really 4 different regions. And if one region gets into real trouble, they'll move blood from one region to another to backfill, because clearly you can't possibly have something that affects the whole country all at once. I mean, this was a feeling that, if we're going to have a disaster like a major earthquake or hurricane or something, it's going to be localized, and we should be able to backfill that. Even if we have a major terrorist event, it's going to be localized. We should be able to backfill that. But what about if we have a pandemic and the pandemic hits the whole country at the same time? Well, then you can't backfill that. So they did some scenarios. And scenario number 1 was a pandemic of influenza. And they took the data from the H1N1 flu pandemic, and they said, what happens to the United States blood supply if there's a pandemic? So 2 to 4 years before the COVID struck the world, the U.S. knew what would happen if there was a pandemic. And their second one was a detonation of a thermonuclear device, an atomic bomb going off in downtown Los Angeles. Which would be worse for the blood supply? Well, what do you think is worse for the blood supply? And does the U.S. emergency preparedness ready for that? Well, guess what? The worst is a pandemic. The worst by far, and I encourage you to read this paper. It is absolutely fascinating. But the worst by far is a pandemic that strikes. And their pandemic duration they had was for 10 weeks or for 13 weeks. And what happens in a limited pandemic for 13 weeks? Now are we into this? We're into this for 2 years now, almost 2.5 years. And their estimation was that with that limited pandemic, there would be a 500,000 unit shortage immediately and during those 13 weeks, and there would be major problems, and the United States blood supply would crash. And that's exactly what happened when the pandemic showed up in early 2020 into the United States. The effect of a major thermonuclear disaster was far less. It was localized, 179,000 units of blood required, a number of deaths, blah, blah, blah. But it was localized, and the rest of the country, they thought, would rally to the cause, be able to give the blood and deal with the trauma that went on. So as I said, read this. It's fascinating. And blood bankers apparently didn't read it because they still today are wringing their hands about what do we do? What do we do? How do we do this? But they should have been ready for it. So blood supply is a homeland security issue, at least when it comes to these kinds of situations. And still today, I've had 4 talks during that time with the United States FDA, off the record. They won't put anything on the record, but I've had 4 talks with them, and they will neither expand the strategic frozen blood supply of the United States, which is only for the military, nor will they consider exactly how to get a blood substitute regulatory approved. And so the only place that has a blood substitute regulatory approved and under investigation is in South Africa. So on we go. New viruses are emerging all the time. We ought to learn. They're coming up all the time. And this is the West Nile virus data, which was that West Nile virus showed up in 2003, 2004 in the United States. And it rapidly overcame with several thousand patients. And West Nile virus, of course, had catastrophic neurologic implications. But there was a time where in the Midwest, around major river systems in the United States, which tend to harbor mosquitoes, any mosquitoes in Africa, around there, we had 1 in 400 units of blood was tainted with West Nile virus. And it was promoted to all the physicians in the United States that you should only transfuse a patient if it was a life or death trauma. You know what? And I got that letter from the CDC and the United States FDA warning about West Nile virus. You know what happened to blood utilization in the United States? Nothing. The physicians did not heed that warning. So are you and we pushing this rock uphill? Absolutely. There's an absolute bias. And once the blood banks began testing for West Nile virus and discarding those blood units, mysteriously, the West Nile virus catastrophe ended. I'm not saying I know that was a cause, but as soon as blood banks started testing for it, West Nile virus went away. Interesting. Patient blood management has never been more needed than it is right now. This is Arieh Shanders and all the rest of us who jumped on board to say, hey, yeah, take a look at this paper. Absolutely true. There's nothing that's more needed right now, ever more, than during this COVID pandemic. Not just because there's a blood supply issue in those countries that have major blood banking available to them, but because it brings up the point that we've got bias and we've got blinders on and we're not looking at data that's right in front of our face. It is staring at us as scientists, and we're not looking at it. The world has responded with vaccines with lightning speed, but the rest of the treatments have been woefully under-investigated. We need global, low-cost, fundamental ways to treat this disease that will work in emerging countries as well as highly developed, quote unquote, the rich countries. Not everybody can afford remdesivir at $3,500 a treatment over a course, nor can we get it to everybody. What about convalescent plasma? Well, you have to have a very developed blood banking system in the world to get convalescent plasma. And you need convalescent plasma at just the right time in the disease to attack the virus before it gets to the point that the virus is out of control. And so convalescent plasma, although it's been, at least in our media, is not really it's not going to save lots of lives. And you need very high titer. So you need to be able to test for it and get the antibody titers and get just the right convalescent plasma. And so I'm not going to go into this in great depth, but convalescent plasma is not the answer to this disease. But here's the thing. Convalescent plasma from the blood bank makes a lot of money for somebody who's in a blood banking industry. A lot of money, because it's rare, it's in short supply. Also, ECMO is the last resort for COVID-19. ECMO, we can't count on. There are only 250 centers worldwide that do ECMO. You know how many there are in sub-Saharan Africa? I think 3 or 4 in all of sub-Saharan Africa. This is not a treatment that anybody can rely upon. And please don't let me get to the point that I need ECMO as my only way to survive. And ECMO survivability for COVID is still very low. So not a good thing to do. I'm going to skip past the HLA antigens, but it's fascinating that COVID strikes. If you're O positive blood, it strikes you less than if you're B positive, and O negative has at least. COVID hypercoagulability is yet to be fully characterized. We know what will happen in patients if you leave them with the inflammation long enough. Is that a bloodborne effect? Absolutely. What does it mean to the patient if there's cellular debris, oxidized lipids, and all these other things that are coming from cellular destruction that are out there and are turning on essentially a DIC? Well, maybe one of the hallmarks is patients who are showing up with quote unquote COVID toes, where they've got extremities that are underperfused. Their microcirculation is dysfunctional. And what we're also finding out is that there's an iatrogenic play in that almost every patient who gets COVID is in the hospital. I'll say 100% of them are on heparin, one way or the other, whether it's sub-Q heparin, intravenous heparin, or whatever. So is there an overlay? And there's absolutely an overlay of the HIT antibody. And lo and behold, the production of the COVID stuff turns out to have a production of HIT antibody. And most of us don't really understand that. And eventually, over time, it progresses to DIC. Let me get to the last little bit of what I want to show you, which is that we in our work here at University of Florida are trying to create a worldwide low-cost treatment for COVID if it can be used at just the right time. And that's to use inhaled adenosine. Adenosine is a drug that all of us know, and we know it for treatment of supraventricular tachycardia. But as I said, adenosine is important for how the virus gets into the cell, how the virus consumes adenosine. But it's also important that the adenosine is the signaler to killer T cells, to downregulate killer T cells when they come into an inflamed lung. So if we give inhaled adenosine, we will saturate the adenosine deaminase center where the COVID can get into the cells, but we also will downregulate the killer T cells, which go crazy in the lung of a COVID patient that create the cytokine storm. And Pierpaolo Coriale in Italy did this. He did it in 14 patients who were going to die of COVID. 13 of them survived. 13 out of 14 patients survived because he gave them inhaled adenosine, whereas the previous 52 patients that hadn't gotten the adenosine, only about 30% survived. We've done it in 2 patients here at University of Florida, and I've petitioned the US FDA to do a big international trial. And so we're trying to push that forward. There are other papers that support what we're trying to do, but a treatment of adenosine costs $30, at least in the United States. And that's for a 7-day treatment. That's the entire drug cost. Is that a reasonable cost for a drug that could be used in Africa, emerging world, wherever? Yeah, absolutely. But just like everything else, we need to understand when to use it, when it's appropriate to use it, when it's too late to use it, and when it might be of utilization and not. So I've got some very big people in some very large philanthropic organizations who are interested in pursuing this and getting it going as a worldwide trial. So I'm just going to conclude that to me, it's all clear. Maybe it's not all clear. Hopefully it's all clear to you right now. But COVID's in the bloodstream. COVID becomes a whole body disease. And the only way it can become a whole body disease in certain patients, maybe not in everybody, but in certain patients, it becomes a whole body disease. And the only way it can do that is hematogenous spread. It's an endothelial inflammatory disease, certainly in the microcirculation and certainly in the myocardium, in the brain, and the kidneys. So shouldn't we monitor it in the blood? Why are we so blinded to the fact that we should investigate that? Well, all of medicine appears to be blinded by it. And patient blood management has never been more important. ECMO's useful, but only maybe in my center or my part of the world. It's not going to save many patients. It can't save the millions of patients that are out there. Convalescent plasma is a problem. And coagulopathies, there's just so much more we need to learn about it. But ultimately, we need people to take off their blinders and ask the tough questions, even if they are politically untenable.